Uh, we'll talk only about step one. I fear in a conspiracy between me and Sunil, we change things a little bit. What we think we'll do today is just concentrate on step one and then leave step two to Thursday, two and three. So with that idea, let us talk in a bit of a practical way. Okay, attendance has increased to 8. Suppose your grandmother or aunt or your neighbor who is about 70 years old keeps complaining of pain in the knee, both knees, and this seems to be unable even to move about comfortably. She has been going from doctor to doctor. She has got a diagnosis of osteoarthritis. The only solution offered to her was knee replacement, which the orthopedic surgeon himself said at your age may not be such a bright idea, and she didn't want it anyway. But whenever they see you, they are complaining of the pain. Okay, so osteoarthritis, no curative option in sight. And Saurabh, I can see Saurabh immediately thinking, what intervention can I do? There may be solutions in terms of interventions, maybe. Let us think more about it. But your grandmother is asking, hey, give me some tablet or other, I can't bear this. What analgesic would you consider giving her? Take a moment to think and let us think. This is an everyday situation, isn't it? Happens so frequently. What can we do? As no hand has gone up yet, shall I start from one corner? Dr. Sravanti, you have any comment? I will not force you to say anything, commit anything, but would you have any idea? Like you have to get out of the situation. Your grandmother is asking for a tablet. Okay, maybe these are some of the everyday situations that we will think about. I just wanted to bring up a commonplace situation. As Dr. Savanti is not quite sure how to fit the grandmother into the ladder. Hina, can I ask you, may I give her a tablet of diclofenac? No? Hina, you are not audible. Sorry. Now you may be audible. Try again. Hina?
Now?
Yes. We can hear you.
Yes, sir. So first we will give up paracetamol.
Sorry. Once more, Hina, I couldn't follow you.
The paracetamol.
You give paracetamol. Okay, very good. Okay, that's a good beginning. You are playing safe by giving paracetamol. So that may be where we begin. Okay. This ladder that, can you see the screen?
Yes, sir.
Screen has been shared.
Yes, sir.
Okay. The ladder was created in 1986 and it was created specifically for cancer pain, but many other principles would apply. You wouldn't want to put your grandmother straight away on morphine. You would start with step 1. And as you can see, step 1 is non-opioids without adjuvants. For all practical purposes, the only clinically used non-opioid analgesics are drugs belonging to the NSAIM category, non-steroidal anti-inflammatory medicines, and including paracetamol. Is paracetamol a non-steroidal anti-inflammatory medicine? Vajra says no. Vajra says no. Nobody else is committing an answer. Hey, Odette has joined. Hi, Odette. Welcome to the group.
Hi, Raj, and hi, group. Nice to meet you all, long distance. Sorry to be late.
Long distance at middle of the night.
Not too late, not too bad.
So, Odette, we were just beginning to talk about the ladder. As you know, this is the third session. And we brought up I don't think you were here, the situation of an elderly person with the bilateral osteoarthritis pleading for some pain relief. And he now suggested that she would start paracetamol. With that in the background, we were talking about step 1 of the ladder. So for all practical purposes, non-opioids are NSAIMs, I said. But then Vajra objected and says paracetamol is not a non-steroidal anti-inflammatory medicine. Vajra, I will agree with you, but I would like you to know that Goodman and Gilman would not agree with you. But I agree with you, defying Goodman and Gilman, because for one thing, I want to be friends with you. And secondly, because it's a very different kind of medicine. We cannot argue with Goodman and Gilman because it does have a NSAIM property. The peripheral anti-inflammatory effect of paracetamol is not significant in clinical doses. Paracetamol would have a predominant central effect, which is negligible for all the other medicines, NSAIDs. So therefore, paracetamol, though it can be classed under NSAIDs, is a very different kind of medicine. So that's very good, Hina. Let us start with that as a starting point. But, you, when you treat that grandmother, are not going to give her an injection of paracetamol, are you? For a variety of reasons, you would prefer to give the drugs by mouth. But Hina, would you agree to that by the clock? If paracetamol is given, would you give it round the day or only as required if the pain is continuous?
Around the day, 6 hours hourly.
If the grandmother is suffering round the clock, medicine also has to be round the clock. That was mentioned last time. And by the ladder. And attention to detail means also individualization of the treatment. Like this morning, I saw an elderly person with advanced cancer who has severe body ache all over the body. And I prescribed paracetamol. But I gave her paracetamol syrup. Because as soon as she sees a paracetamol tablet, she says, that's too big, I don't want it. So individualizing, customizing treatment to the individual is of course very important. So we will first talk about the non-opioids, starting with paracetamol, then we'll briefly go on to the adjuvants. I don't have to read it out, but you make sure that you do some mental calculation and discover the appropriate dose for you if you have to take it for a headache. Calculate it. Gina, calculate it. You don't have to tell me. I don't want to ask for anybody's body weight. But did you calculate? And if you did, can you tell me, have you been, when you needed a dose of paracetamol, have you been taking this dose or less or more? Gina. Gina, comments? No, you are not out. You are still muted. Okay. Okay.
Less,
You have been taking less. Okay. So now I am making a statement that this is quite safe, and for optimal effect, whether it's a fever or pain, this dose should be taken. Just because one tablet is usually available, I mean, we take one tablet and that's not quite scientific. And maybe much higher doses when your child is having fever. You know how distressing it is. Everybody knows that. So up to 15 milligram per kg 4 hourly may be acceptable over the short term. Maybe a day or two. That should be quite safe. Even higher doses may be safe, but we are trying to play as safe as possible. Any comment about the dose of paracetamol? And I am making one more statement here. And because I may not be believed, I am giving the reference also that even in the presence of a patient with cirrhosis, for example, a chronic liver disease, paracetamol is safe, and that has been established. And this, mind you, is not just any one study. This is a systematic review. Assuming that that is not being challenged, shall I move on? Okay, now I'm done with paracetamol there. I'm not going into the details. I don't want to talk about the current disease of giving everybody intravenous paracetamol whenever you get a chance at an enormous cost, which is most of the time unnecessary. And if these 2 points are remembered, I will be very happy. Now, before I go on to other non-steroidal drugs, just one statement. Even for somebody going on to step 2 or step 3, most of us are used to continuing this. Remember that in step 2, it is weak opioids and step 1. Okay, so we would continue this because the paracetamol or whatever non-opioid we are using will lay a sort of foundation so that the number of patients getting some toxicity with opioids will be less. So along with paracetamol, when you give tramadol or morphine, it's likely to have better quality analgesia with less of side effects. Dr. Bharani, we have just talked about paracetamol. So when Shiva sends you the...
Yes, sir.
Okay. Okay, you were here, sorry. So now we are going to talk about all the other non-steroidal anti-inflammatory medicines. As I said, with clinical doses of paracetamol, these are unlikely, though some people may get gastric irritation even with paracetamol, but mostly this is for all other medicines. Now, even if we forget most other things that we discussed today, I mean, these are basics, so many of you may get irritated by me harping on these basic things, but it's very important. One of the things that I do, I'm not preaching anything that I'm not practicing. Before making any single prescription for a non-steroidal anti-inflammatory medicines, I will ask these three questions. Is this patient prone for gastritis? I will ask the patient, you must have taken medicines like ibuprofen or Vovaran, etc. some point of time. Do they give you a stomach trouble? I will see if the patient already has any borderline renal disease. I'm not saying that I will insist on a serum creatinine for everybody. I don't do that. Many people might. I wouldn't. But I would ask for any history suggestive of renal disease. I'll also ask for any history of any hemorrhagic tendency. Just about an hour back, I went to the ward and suggested that Amrita to give a non-steroidal anti-inflammatory medicine to one patient. And Amrita, no, Sunil immediately objected. Sunil said this patient already has a recent history of hematemesis. So any bleeding tendency also we'll consider an objection. So for every prescription, we ask ourselves, is he prone for gastritis and gastric erosion? Is he prone for renal disease? Is he already having a renal dysfunction? Is there a bleeding tendency? Any comments? Personally, I have a mental picture of the stomach, the kidney on the one side, and the blood flowing through the aorta between. Stomach, blood, kidney. Three things we'll always remember. And particularly regarding the stomach, let us try to remember that gastric erosions can be silent. As many as 20% of gastric erosions can be silent. And the first manifestation can be a perforation and the patient ending up in the emergency room for a laparotomy. You will not see the patient, you wouldn't even know that it has happened, but that patient is never going to come back anymore. So it is something to be remembered for everybody, not necessarily for those with a history of gastric toxicity. And renal toxicity, hey, wait a minute, why all these three things? This is because non-steroidal anti-inflammatory medicines block prostaglandins, and prostaglandins are necessary for normal function of these organs. And that holds true for the kidney also. In the absence, when prostaglandins are blocked by your diclofenac or ibuprofen, then renal cortical blood flow will be less. Ordinarily, it does not matter. Even if cortical blood flow drops a little bit, nothing will happen unless the patient is already dehydrated. If the person is already dehydrated or hypovolemic or already has an existing renal dysfunction, then this can dramatically worsen the renal dysfunction. And because they may have the effect, because of the renal cortical vasculature being affected, they may have more of water retention. So it is possible that if a patient has a hypertension BP may go up a little bit, or a impending cardiac failure can become an overt cardiac failure. They are less common. With that, we come to the inevitable question of COX-2 selectivity. I will not labor this point. Some of you know this already, some of may have a confusion. So I just mention this and move on. Normal metabolism of fatty acids in the body, normal metabolism, can involve two enzymes. Normal or constitutive, what is there in our body ordinarily is COX-1. You need the COX-1 for your stomach, the kidney, the platelets. For normal function, you need it. COX-2, cyclooxygenase 2, is liberated at sites of inflammation. They sensitize the nerve ending to action of pain-producing substances, and therefore that prostaglandins in sites of inflammation contribute to pain. So what you really need is blocking the COX-2 cyclooxygenase 2 pathway. Ideally, if we could do it without affecting cyclooxygenase 1 at all, you should have perfect pain relief without no side effects. But unfortunately, that perfect mechanism has not been invented yet. So, this ideal of no adverse effects are simply not achieved. If we use the COX-2 selective drugs available now, do you use them? What COX-2 selective drug do you use? Etoricoxib. So if we use it, what we expect is that it would have less gastric irritation than other drugs. But remember, important point, can't afford to forget it, very important. COX-2 selective drugs do not offer any protection for the kidney. Your etoricoxib can cause as much renal dysfunction as any other medicine. And on the platelets, however, etoricoxib or other COX-2 selective drugs are not likely to cause additional bleeding, but on the other hand, by unopposed action of thromboxane 2, COX-2 selective drugs may promote thrombosis. Confusing? COX-2 selective drugs will cause lesser gastric irritation, will not promote bleeding. So if you have a patient who has a bleeding tendency and you desperately need an NSAID, you can give etoricoxib. Patient is unlikely to bleed. But what we just now said is, not only does it prevent bleeding, it actually swings the pendulum the other way and may cause more thrombosis, and therefore a COX-2 selective drug is likely to cause thrombotic events and is more likely to cause a cerebral thrombotic event, a stroke, or a myocardial infarction. So they have limited application, though the medical representatives may tell you otherwise. So now that we know, we are coming back to the grandmother. We are coming back to the grandmother with osteoarthritis. As Hina correctly said, the diclofenac or ibuprofen should not be a first-line drug. We'll certainly try to avoid that etoricoxib for her because it may give her a heart attack after a few months. So the first choice would be paracetamol. It is unlikely to be as effective as another NSAID because of the less anti-inflammatory action, but that should be reasonably safe even if your grandmother takes it regularly over the long term. Now, many people take aspirin. In fact, American Heart Association recommends that any man over 50 years and any woman over 40, and any man over 40 years and any woman over 50 years should take aspirin as a routine precaution till the age of 80. But remember that the combination of ibuprofen with aspirin may reduce the cardioprotective effect of aspirin, and if at all you take it, we shouldn't take it together. A gap must be put. And even low dose aspirin taken along with this is shown to increase the chance of gastritis. That's one practical point to be remembered. The second practical point to be remembered is the choice of the NSAID. In our unit, till about 2011, Sunil would remember, we used diclofenac as the NSAID of choice. I mean, for anything other than paracetamol. That's what we used to take. Then these people, Forsbol et al. Did a study covering the whole of population of Denmark by studying 10 years electronic medical records. And they found that many medicines, at that time rofecoxib used to be used, diclofenac and high-dose ibuprofen also increase the cardiovascular morbidity. Chance of myocardial infarction was high, even with diclofenac. And they found that the safest were ibuprofen and naproxen. Ibuprofen limited to 400 milligrams TID and naproxen limited to 500 milligrams twice daily were the safest for the heart and the brain. So after that, we here switched over from diclofenac to ibuprofen for routine use. There may be difference of opinion about other aspects, but available evidence shows that long-term diclofenac is bad. So Hina, for the grandmother with osteoarthritis, if we can manage with your paracetamol, fine. But suppose there are periods of worsening, and if she still desperately needs something, your choice would be ibuprofen or naproxen and not diclofenac, because that need may happen again and again. Even if you prescribe it only for 3 days, this is India, free country, anybody can buy anything anywhere, and if they find something, they may continue to take them. Can I ask you if there are any questions about anything that has been so far mentioned?
Can I ask a question, Raj?
Yes, Sunil.
So, does that change a non-steroidal to naproxen or naproxen? Does that apply to the patients with a more limited life expectancy also in your unit?
No, absolutely right. When we continue to use ibuprofen, it's only a matter of convenience. We have nothing against ibuprofen. But thank you, Odette. Thank you for the point. So, our advice to avoid diclofenac holds true only for those who are likely to continue it for a long time and in whom there may be a higher chance of myocardial infarction or stroke. So, anybody with a limited life expectancy, it's not valid. Thank you.
Thank you. And do you have a parenteral form of non-steroidal available?
We do, but not ibuprofen or naproxen.
Okay. Thank you.
So here would be the summary of my recommendations regarding non-steroidal anti-inflammatory drugs. Always use gastroprophylaxis. Can I take a vote? Which will be better, proton pump inhibitor or H2 blocker? All those who choose H2 blocker, please raise your hands. 1. Those who choose proton pump inhibitors, who raise your hands. 2, and there are 3, 4. There are some invalid votes I see. So here would be my answer. I agree with everybody. Proton pump inhibitors are believed to be more effective, but evidence is not so strong. So particularly considering that this is a poor country, those like me, cheapskates like me, who always go for cheaper medicines, can go for H2 blockers. That's okay. It's okay to choose either. Proton pump inhibitors may be marginally better. What is not acceptable is not to use it without gastroprophylaxis. At least H2 blockers must be given. Secondly, for long-term administration, ibuprofen and naproxen appear to be the safest as current evidence goes. For all practical purposes, now we will consider diclofenac to be a COX-2 selective drug. And if you do use a COX-2 selective drug, whether it's cetorecoxib or diclofenac, in answer to that was Odet's earlier question, use it for the short term. That may be safe, even the cetorecoxib should be safe enough, even in the presence of a bleeding tendency. And with that final point, I'll stop about NSAID. What was not known so clearly earlier, and what is very clearly understood now, is that presence of respiratory infection remarkably increases the chance of myocardial infarction if you are prescribing non-steroidal anti-inflammatory medicines. Sorry about the power failure. Are you still able to hear me? Delay. So remember, non-steroidal NSAIDs plus respiratory infection is a dangerous combination. So here are a few pledges that I would request everyone to take. I will remember the stomach, kidney and platelets whenever I prescribe NSAIDs. I will always educate the patients about gastroprophylaxis, about never taking NSAIDs on empty stomach, and about avoiding dehydration. If you are taking an overnight bus and you avoid drinking waters to avoid using the toilet, do not take NSAID. And for long-term administration, choose ibuprofen or naproxen and use COX-2 selective drugs only for the short term. These are the pledges that we have to commit ourselves to take. Shall I answer any question about NSAID before moving on to adjuvant? No questions? maybe afterwards. I'll finish adjuvants also. I'm not going to take long about it. It's only an introduction. So step 1 is non-opioids with or without adjuvants. Adjuvants are drugs that have no intrinsic analgesia, but which in a particular context causes analgesia. And adjuvant analgesics, for example, are if the patient has a severe abdominal colic, dicyclamine or hydrogen butyl bromide would cause pain relief. That's what we should be using. Right? You get the idea? Everybody understood what adjuvant analgesics are? If you cut your arm and you have a pain here, then dicyclamine will not relieve the pain. But if it is your child has a colic, you will need one of these medicines. Shall we think of some more examples of adjuvant analgesics? Or better still, I will give you an exercise. This is a patient whom I treated. I mentioned that he was a Gandhian because in his pain, this Gandhian, ardent Gandhian, actually pleaded with his son to buy him some alcohol, hoping that alcohol would reduce the pain. He had pain in the tip of the pain in the penis of he had a man with the cancer of the prostate, and when every few minutes the pain will come on, then it will last for 10 minutes, and this would happen more than once every hour. In 6 months, he had not had one single good night's sleep. Sunil, do you remember this person? Sunil remembers this person. And he said he has often been thinking about suicide. Only the thought of his children and how much they will be ashamed prevented him from committing suicide. He had got paracetamol, every possible NSAID, and finally a doctor had given him morphine. Morphine made him very drowsy without pain relief. And because it was tried for several days, he had not been eating or drinking anything. So we said adjuvant analgesics. So all conventional analgesics, non-opioids and opioids had failed. What can relieve this man's pain? So in any situation like this, instead of mechanically climbing up the ladder, you ask, why is this man in pain? He has cancer of the prostate. Why does he have cancer in the pain in the penis? The obvious likelihood is that the cancer must have infiltrated to the trigone of the bladder, causing bladder spasms. The typical presentation of a bladder spasm is pain shooting to the tip of the penis. So when somebody says my pain is over the penis, then you ask, is it a pain that goes from the hypogastrium towards the tip of the penis? And that's fairly typical of bladder spasms. His pain was remarkably better, and he lived for about 6 months free from pain, most for the pain. But it took him several days or weeks to recover from the weakness that had happened during the months of pain. But that was a remarkable improvement. So here, the anticholinergic oxybutynin was the adjuvant analgesic that helped him. Okay, I have mentioned colics and dicyclamine. I have mentioned another that we use to decrease the bladder spasms, oxybutynin. Now tell me some other adjuvant analgesics. Anybody?
Sir, amitriptyline is there in the book, sir. Amitriptyline for neuropathic pain. Tricyclic and
for what pain?
for neuropathic pain, sir.
Absolutely. Very good, Gina. Thank you. So, and Gina, I am particularly saying there's no way in which we can take a chocolate out and give it to Gina to encourage her. Electronic chocolate. Gina, that would be cruelty. Already this is clear. Gina, I'm particularly happy about your answer because you also chose the least expensive analgesic. I think most people would have immediately said pregabalin or gabapentin. But Dr. Bharani,
That's the only one I'm reading up in primer, sir.
Dr. Bharani, what is behind your smile? Did you smile because you immediately thought of gabapentin or pregabalin?
No.
No. Okay. Now, I do not have much more time. We are not going to the details of medicines for neuropathic pain. We will talk about when I do another session on difficult pain. The discussion on, I have by no means covered all adjuvants. I have not talked about drugs used in neuropathic pain at all. As Gina said, amitriptyline or other tricyclics, or as I said, anticonvulsants like gabapentin or pregabalin, are all drugs used in neuropathic pain. They are also adjuvants. If you use a muscle relaxant in a skeletal muscle spasm, that's also an adjuvant. So, going back to the ladder, we have talked about step 1. Paracetamol we talked about separately. We said limit the dose to the minimum dose necessary is 12 milligram per kg 6 hourly, at least 4 times a day. We mentioned that when we use any other NSAID, we'll remember the stomach, the kidney, and the platelets. We said that for long-term administration, or for any administration, gastroprophylaxis is a must. We said that for long-term administration, ibuprofen and naproxen may be safest. And we said that if you use a COX-2 selective drug, which must be for the short term, and I also recommended that diclofenac must be considered a COX-2 selective drug in the light of recent evidence, because it may increase the chance of a stroke or a myocardial infarction. And in adjuvants, we did not go into all the possible medicines. We deferred discussion about neuropathic pain medicines. But can you look at the second paragraph on the screen? Gina already looked up for something and got up to amitriptyline. So Gina, keep looking. If you look for systematic reviews or meta-analysis about neuropathic pain, you may find some interesting things. Let's collect the evidence. I must admit to some bias against expensive medicine. So let us not be biased by people like me. Let us look at available evidence. And I'm hoping that you wouldn't mind doing that homework before we talk about difficult pain in a few weeks. Questions, please. Any question? Gina, did you raise your
Sir,
hand?
will you send us sir, does that mean the MCQ in the assignment? So what was the answer to that one, sir? The one on neuropathic pain? And not the one that was the least sensitive to morphine. There was one question that I almost did a systematic review within the house, and I didn't get an answer to that.
Look, I didn't get the MC. I mean, like that's an error on my part. I did not look at the MCQs in advance, and that it will not happen again. Between Sheba and I, we are making a pledge that I will be ready with the MCQs before I do another session. Sorry that this happened, but Sheba is desperately trying to find the MCQ so that I know what you are talking about.
So the MCQ was which of these is least sensitive to morphine? There were 4 choices.
So what are the choices?
So the first one was neuropathic pain. The second one was ulcer pain. The third was muscular pain. And see, the fourth one I don't remember.
Bone pain. It's a bone pain.
Bone pain.
Bone pain.
Okay. If I try to answer the question, there are 2 risks. Sunil is going to talk about opioids next week. He is going to be very annoyed. My second problem is I may give the wrong answer. So let us wait till Thursday. We will come back to that question after Sunil has talked about. Okay. So I thought it was Sunil. It's going to be Nandini. I'm sorry. When after Nandini has talked about it, we will come back to the question. And Shiva, make sure that Nandini has the MCQs. Any other question about things that we have talked about today? And another mistake that I did was that we gave the schedule as step 1 and 2. Instead, I have done only step 1. So step 2 and 3 are to be done next week. That's not so any question about step 1 medicines and except that's for neuropathic pain, which as I said I will cover during typical pain session. Dr. Somaraju? Dr. Somaraju. Dr. Somaraju, do you have a question? I don't think Dr. Somaraju heard me. Anybody, any question? Odette, comments? Sunil? They don't.
Maybe can I make a question or comment? Just in your experience, Raj and Sunil and others, do you think that the incidence of side effects of non-steroidals is any different in India compared to what might be in the literature due to dehydration or other factors?
I honestly do not know it because neither Sunil or I have worked in any other country, so we cannot compare. But I have read that the commonest cause for acute renal failure in our country is iatrogenic causes. And among the iatrogenic causes, the commonest of causing acute renal failure is NSAIDs. So
I wonder about that because people rely so much on non-steroidals in pain management because of the lack of opioid use. And also, I mean, I had the experience with my son who was actually in the USA with acute appendicitis. And he had this, post-operative need for pain relief, and he was on 4-hourly morphine, some small dose. And he had about 20 minutes to go before the next dose of morphine was due. And there was a lot of concern about giving him the morphine too soon, which is a common issue, isn't it? to the extent where they suggested that he have ketorolac instead of morphine, and because of my concerns about non-steroidals and their side effects, I wouldn't let them do that. But perhaps people think of non-steroidals as a safer drug than opioids, and yet for me, I would much rather him have a dose of morphine in that setting.
Thank you, Odette. I think when we leave that discussion, that will be a main take-home point, that there is common perception of NSAIDs as safe medicines, whereas once you understand the medicines, opioids are so much safer. That doesn't mean that for all musculoskeletal pains, you will start with opioids as a first-line medicine, but by its pharmacodynamic actions, that they are actually the safer group of medicines once we understand.
Absolutely, I agree.
Thank you.
And far more predictable in their side effects, morphine or opioids, than are the non-steroidals. As you said, often the gastric complications are hidden. The renal complications can catch you completely unawares, and so forth. So,
And because they are over the counter, I mean,
over the
you wouldn't
counter.
give opioids in this country. This is what they can get. And I have repeatedly seen people with ischemic pain,
Yeah.
following any number of tablets and then worsening the renal failure.
Interesting. Interesting. Thank you.
Okay. Okay. So who is doing the case presentation today? Vajja?
Sir, I'm doing the case presentation, sir. I guess Shiva has the slides, sir.
Yeah, it's coming on. Just give me a second.
Before I just start the presentation, sir, I just want to tell that because I'm not working with, right now I'm not working with the people who are having cancer or other thing. I just got, I had this patient who has this bone pains. So we treated her in a different way, and there was some mistake we did, as well as the way we have seen the patient was little things. So I just want to highlight, because we treated her with COX inhibitors. This patient, I had to hide the name because of the patient didn't want me to tell the name. A female patient of 18 years old came with the complaints of body pains, and she complained that she was unable to write and walk for the past 6 weeks, and even she has pain while eating also. Like when she wants to take food with the fingers, she had difficulty in pain. When I want to tell the history in detail, she has generalized pain for the past 6 weeks. She went to a local doctor and she took paracetamol and ibuprofen, but she was not relieved of the pain. And when we go in details of the type of pain, as we learned last time, the PQRST of the pain, provocative factors was while walking, while writing, even at rest, she had pain. There was no relieving factors as such. Even she's on medication, the pain was not relieved. The pain was dull aching, and the pain was more on the small joints of the hands, of the wrist, and both the ankle joints, even the low back ache. So she was having difficulty in all these joints, and the pain was moderate to severe. She was like, sometimes she says it's very severe when she's trying to do any work or when she's trying to go to college. If not, she's better, okay, but there was no relief. The time, when we took the time factor, she has more pain during the early mornings with the stiffness, but the pain was continuous. It was all the day through. When we look back at the past history, she had similar kind of joint pains, but not the severity was little less, which was associated with fever. She was given paracetamol and ibuprofen, and then she was relieved of it. After that, she didn't have any symptoms for the the past 3 months. And the similar complaints she had, the similar kind of pains, when we asked about the pain history, she said she had the similar pains 4 years back, but at that time she had fever and rash and was diagnosed with chickenpox, and she used some homeopathic medicine. She didn't use any allopathy medicines. Regarding her personal history, she's a student who is studying degree first year. Family history was both parents were working, and there's no history of family history of joint pains or arthritis related issues. And physical examination, the weight of the patient was 60 kgs with a height of 157 centimeters. All the systems were like normal. When we looked up at the cardiovascular system, thinking because she has joint pains, it might be related to rheumatoid arthritis or rheumatic fever, kind of, because fever was there. This CVS was normal with no murmurs, and per abdomen it was normal. Respiratory system was normal. CNS was also normal. No other significant findings in the physical examination. When we examined musculoskeletal system, she had tenderness over the joints, the small joints and metacarpopharyngeal joints and interphalangeal joints. She had mild restriction of the movement. The joints look little stiff. Next slide. We went on with the investigations. Investigations were normal when we looked in ESR, the dsDNA, and the rheumatoid factors, CRP and ANA. Everything were within the normal limits. So we were wondering how could we relieve her pain. So we started initially on the next slide. We started on celecoxib 100 mg twice daily for 4 weeks. We actually gave it for initial 10 days. She said it was better, the pain was better, so we asked her to continue for 4 weeks, and we gave ranitidine 150 mg twice daily, and we even advised her physiotherapy. Then we asked the patient to review after 4 weeks, and the patient came, and she was still complaining of the pain, and the severity was not much decreased. It was still the same. After 4 weeks, we increased the dose of celecoxib, 200 mg twice daily. Initially, we thought we'll continue for 6 weeks and then ask for the review from the patient. This time, we gave lansoprazole 15 mg and celecoxib advised physiotherapy. After 6 weeks, still she had pain. So we were wondering, we did miss something here. So we again went back with the history again. So the final time we could ask this, the history was from the parents' side and from her. After the 6 weeks of the period, because the pain is not reduced, I spoke to her personally, and then I asked her what exactly, when the pain increases, what I could even take the psychological history also. So she was a little upset that she's away from her parents because she's doing her graduation far from her parents. So then we referred her to the psychiatric clinic for the further evaluation to see is there any adolescent adjustment disorder or not. So I'm just waiting for the review from the psychiatric people.
Participants have any comments?
Sorry, I just forgot.
Yes.
Sorry, I just forgot to say that X-rays, we have investigated her with a radiological examination. To X-rays didn't show any findings of the arthritis. So that also ruled out that it was not the case of the arthritis, rheumatoid arthritis. So I was just thinking recently it might be a reactive arthritis because of the psychological issues she had.
Vaja, the pain was consistently over the joints.
Yes,
Small
sir.
joints also.
Yes, sir.
And because she did not respond to her medication, we suspected the psychological issue. And
Yes.
the emotional issue could certainly be worsening the pain experience. but it appears that because of the consistency of the pain, and she also talks about the pain being worse in the mornings, right?
Yes, sir.
Now, I am out of my depth. I wish I had a rheumatologist in the room or at least an internal medicine person in the room. But nevertheless, I am so happy that Delamy, Sunil, and Odette are here who might be able to give more advices. But uh, there are two things that we'll discuss here. One,
Yes.
he talked in the beginning, I mean, no, on the second day, I think, when Mary was making a presentation, that we as people who treat pain will remember never to miss a correctable factor. If there's a basic disease that needs to be addressed, and the fact that we are giving the pain management shouldn't limit the disease specific treatment. So I was wondering if a general physician, internal medicine person, or a rheumatologist might either investigate more or proceed to empirically treat her as a seronegative rheumatoid arthritis, especially with the history of the morning burst severity of the pain. Would anybody, is anybody among the participants general practitioners?
Sir, not a, sir, just I had an opinion, sir.
Yes.
Sir, I had an opinion.
Yes, Dr. Bhatt.
Sir, since multiple small joints have been involved, so it appears to be a past part of a generalized systematic disorder than a local pathology. So, and our intervention are more directed towards the regional cause or so probably a evaluation by a general physician or a rheumatologist will identify a systemic cause for the joint pains.
Thank you, Dr. Bharat. So, thank you for, exactly the point that I was making. Vajja, is that a
Sure, sir.
practical thing? Very often we come across a situation. The patient is in a village, in a rural area. We cannot get the person to a person where a formal consultation can be made. That's a reality. Ordinarily, they are ignored by the medical system. We pretend that they do not exist. In this case, is such a consultation possible? I particularly was wondering if she should be treated as a seronegative rheumatoid arthritis.
Sure. It's possible, sir. I'll just recommend that.
But wait a minute. There are more knowledgeable people here. Helen.
I'm speaking from my experience of 15 years of general practice. So I think an 18-year-old woman with such persistent, severe pain certainly needs further investigation. But the most important thing really is that you have shown your commitment to hearing her story and treating her pain. So using even the medication you've used will not mask her diagnosis. So it's really important that you continue in your journey with her and bring another specialist alongside.
Thank you. Thank you, Villami. With that 15 years of GP experience, better than a specialist. If the challenge that we often face, like that a rheumatologist would order a battery of investigations, particularly looking for any autoimmune disease, etc., most of it will not happen. Because of the financial problem, for many of our villagers with this kind of thing, the rheumatologist is unattainable. This will be a bit difficult for you because you may not face the same situation back home. But when we are faced with that situation, sometimes we are forced to treat people empirically. An MRI is not possible for something, we assume a disc prolapse and treat for, not in this case. So, I would be, I don't know, Delamy, but I would want your frank opinion. So, not your country's situation, but a proper evaluation not being possible. If I attempt, say, salizopyrin or methotrexate or something with a therapeutic trial, would that be ethically acceptable?
It absolutely would be ethically acceptable. And I think as doctors, we need to be able to adjust and research and look things up and accept the limitations that our patients bring to us in terms of their resources and do our very best. And when we do that, we learn alongside our patients. So it would be a good thing to look up the treatment of seronegative rheumatoid arthritis and decide whether you're comfortable about doing that treatment.
Sure, sir.
But what I do is sometimes when I cannot get a specialist to see a patient, I just talk to a friendly doctor, an internal medicine person. Rheumatologists are not easily attainable. They are somewhere up there. But an internal medicine person, get their advice, unofficial advice. Many of them would simply refuse to treat without any investigations. So unofficial advice, and I would go ahead and do it. So when personally, that's what I would do in this case. One, talk to an internal medicine person, give him the story. About the emotional component, I'll assume that the emotional component may be making the pains worse. But when it is localized and consistent,
Yes.
just the hypothesizing that the whole thing is psychosomatic may be far-fetched.
Okay, sir.
Odette, GP experience? Comments? Odette is
Just trying to find unmute. No, it's. I think what you've said, what everybody has said so far, sounds very sensible. And no, I don't see a lot of. Other than cancer, my general medicine's pretty rusty. But from first principles, again, believing the patient and being very careful not to give a sense that this is somehow, psychosomatic, and while taking the emotional side very important, very seriously. I think the ongoing relationship with you is going to be extremely helpful for this young woman who, because to not have a diagnosis can be a very distressing thing in itself. It would just be something else to add.
Thank you, Odette. But the second point, of course, is about, as you must be ready to comment on your own presentation, is about the choice of the non-steroidal anti-inflammatory medicine that you use. If nothing else relieves the pain and the pain is severe, I also wouldn't, I certainly would not use a long-term NSAID as a first-line measure. But if nothing else relieves the pain, I would be using it. But now that you have heard my presentation earlier, would you have your own comment about your choice of celecoxib?
No, I wouldn't. I actually, after listening to the presentation, I was thinking initially I would give her the continuous dose of paracetamol, or I would put her on naproxen or ibuprofen.
If my hypothesis is correct, and if she does have a small joint disease, of course she has large joints also, but predominantly a small joint disease, with that significant inflammatory component, I suspect that paracetamol may not be adequate. I would still give it a try. A proper dose, 12 milligram per kg, 4 times a day. I'll repeat to the patient thrice that thrice a day is not enough. But after doing that, if necessary, as you say, I would go for ibuprofen because many of us have more experience with that than with naproxen. And there's a general feeling which is not evidence-based that ibuprofen 400 milligrams twice a day would be easier on the stomach than 500 milligrams of naproxen twice a day. But that's only a feeling, not evidence. So yes, ibuprofen. So what all will you tell the patient before you send the patient home with the ibuprofen?
The first thing is I would advise her to take plenty of water, not to just avoid not to dehydrate herself. The second thing, take medicine only after having food and not to skip her meals or anything. And as I would advise her, I'll put her on H2, that ranitidine. So I would ask her to take before food and then ensure that she maintains the gap between the food and the tablets so that she will be away from the side effects of the thing. And I would even tell her, in case if she's having any burning sensation in the stomach or the chest region, maybe she can return to me and take my consultation. These are the things I would advise her, sir.
So, and that takes a couple of minutes, but those are 2 minutes well spent for every patient.
Yes, sir.
If we are taking the
Yes, sir.
responsibility to prescribe NSAIDs, we take the responsibility to give these explanations to every single patient.
Yes, sir. Thank you, sir.
Ladies and gentlemen, comments please, or questions. Okay, if there are no questions, are you sure there are no questions, or should I wait for a few seconds more for questions to emerge? Who has not spoken to me today at all? Dr. Shravanti? Who's Dr. Gireesh? Dr. Jagadishan, are you still with us? Saurabh? Dr. Jagadishan, you are muted. Dr. Jagadishan, unfortunately, is irrevocably muted. Okay, sorry about that. Anybody else? Any question or comment? Okay, then let me then bring up a couple of. Sorry, did somebody speak?
Sir, actually, Dr. Shravanti just put a comment saying that does a small dose of steroid can help her? She just put a comment. Maybe.
Oh, I'm so glad that you brought it up. So, by this time, because Vajja has not been very effective, this is the time when her patient is likely to visit other doctors. And if another doctor sees her and makes the same assumption as me, she is very likely to go on corticosteroids. In fact, the majority of patients with a diagnosis of rheumatoid arthritis in our rural areas, where they do not see big time specialists or even some specialists, straight away put patients on corticosteroids. So, in rheumatoid arthritis, that is ordinary disease modifying drugs would include the salicylates, hydroxychloroquine, methotrexate, and of course corticosteroids. Corticosteroids are most likely to give relief. But I'll think 5 times before I start her on corticosteroids. I will do it only if all the other disease modifying drugs have failed. That would be my last resort, because we are in palliative care and we see patients for long term. We repeatedly see these patients. who suffer more from the consequences of long-term steroids than from the original disease. Very labile diabetes, and as time goes on, the bone phase and hypertension and all the consequences. So especially in an 18-year-old girl, I wouldn't. It is very tempting. I mean, if at all I use it just to try, let's give it a trial. I would have it clearly understood by her. This is a trial, time bound, so many days, but you must come back to me. And you should not continue without consulting me again. So it's easy to destroy a life with corticosteroids. Yes, sorry.
Sir, regarding this discussion about topical non-NSAIDs, the what we had been taught is that topical NSAIDs like diclofenac gel and these should be discouraged, because if the patient is taking oral NSAIDs, we know how much he is taking. If patient is prescribed topical NSAIDs, so he or she may use it too frequently and the dose gets unmonitored. And the systemic side effects of topical steroids are the same as similar to oral NSAIDs. So topical NSAIDs like diclofenac gel creams, they should be discouraged for local application.
Now, Dr. Bharat, thank you for the comment. I must confess that I have never really looked at the evidence regarding topical NSAIDs in depth. Now, one thing that we must remember is that any local application has a significant placebo effect also. It helps. See, instead of saying there's nothing to be done and just take the tablets and tablets do not help, when you give anything, which is why the tiger bombs of the world are so popular, and it gives you something to do, it gives you some control. Especially if a loving partner is applying it and you are spending time together, it certainly gives pain relief. But even otherwise, local applications give you a psychological well-being. It also gives you something that you can do. So anybody is aware of the evidence base about topical NSAIDs? So,
Sir,
Dr. Bharat, between you and I, shall we do that exercise? Shall we just collect evidence arising from randomized controlled studies or meta-analysis or something about topical NSAIDs and be there to discuss that when we discuss critical pain? Can you do it? I'll also do it.
Sir, right now, since we have been not prescribing topical, sir, I was talking about topical NSAIDs like diclofenac creams and gels. I agree.
Yes, I agree. I'm just suggesting that we look up evidence base for or against topical NSAIDs. Okay, let's do that and then we'll study that.
Sure, sir. And sir, I agree with you that it gives a placebo effect. Sir, am I audible?
Yes, yes, yes.
So, sir, I agree that topical application gives a placebo effect, and partially because of the gate control theory, also the patient gets relief. Just my point was that instead of using topical application of NSAIDs, we can we give topical ointments or emollients for that psychological benefit?
Actually, that also brings up one more issue there. As adjuvant therapy, not drugs, topical applications, hot or cold, they are very common, isn't it? So, what's the mentholated creams, which cause a sense of cold In a patient with inflammation, anything that causes cold may be better. Whereas if there's a muscle spasm, a cold may be bad. Heat is bad in presence of inflammation, but cold may be good. So especially those cooling creams, etc., may have a significant give some relief. Thank you for that comment about other creams, etc. Vajan.
Hello.
Sir,
Yeah.
Dr. Shravanti again posted one more thing saying that is it post-febrile illness causing joint involvement?
Sorry.
Is post-febrile illness causing joint involvement, sir?
Vaja,
It's like in my case.
that's very good thinking, because some of those viral fevers can cause prolonged joint pains. But you know the history.
Yes. The thing is, fever was only 3 weeks back on one she had, but at that time she was given paracetamol and brufen, sir. And after that, she didn't have pain for a longer time. For next 3 weeks, she didn't have pain.
Okay. So typically, with those viral fevers, during the period of fever, there is severe joint pain. It is not specific to smaller joints, but this patient also had back pain also. It's generally all joints. And in that 3 weeks gap, I suppose makes it unlikely. But when I say that, I am aware of my inexperience as a GP. Did somebody else speak up? It's probably okay.
Hello.
Anybody else?
Hello.
No.
Hello.
Yes.
Am I audible? Sir, myself, Dr. Manoj Kamal. I want to discuss a case. Today, I saw a patient of 73-year, although it is not related to today's topic, but patient of suffering from chronic pain. He is a 65-year female patient suffering from backache and with radiculopathy, and he had disc bulge at L3, 4, 5 level, or also a listhesis at L5 as well. She is already on medication from last so many years, and she will discuss she short consultation from many pain physicians. And today someone referred to me. The surgical fellows told that it is not surgically fit patient. So how we will manage pain in this patient?
Okay. You did say radiculopathy, right?
Yeah.
Okay.
Yeah.
Like when we have anybody with a backache in our country gets an MRI if they can afford it, and most people would have some disc prolapse. So what I would look for in that MRI report is whether the disc prolapse is associated with either a nerve root compression or a cord compression. Just the presence of a disc prolapse, unless there is nerve compression, I may not associate. But because there is radiculopathy, it's very likely that the prolapsed disc is compressing the nerves. Do you remember the MRI report?
Yeah, disc is also compressing the nerve root, and there is a the height of vertebral body is also less anteriorly. So there may be collapse of vertebral body also. So there must be definitely there is compression, but surgical fellow told that bones are very osteoporotic. They are so they are not able to help her, and she sent and they sent to us. So how we will manage this patient?
Doctor, did you say that your name is Manoj?
Yes, sir. Yes, sir.
Thank you, Dr. Manoj. Thank you for raising that question. I think there is a session on interventions in a couple of weeks or next week, and we'll certainly bring it up at some point of time. But here, let me give you my personal opinion. Even if the general condition was good, and even if the bones were not so osteoporotic, nowadays neurosurgery is generally avoided unless there is motor involvement. Purely for pain management, it would not be used. No,
Motor involvement is not there.
Sorry.
Motor involvement is not there.
Okay. So ordinarily, even if otherwise surgery would be avoided by majority of neurosurgeons, because of the chance of what we call a post or a failed back syndrome. Like immediately after the surgery, there is total relief. But in 6 to 9 months, a good percentage of patients get a new kind of pain, which is worse than the original pain. So, which is why most of the time, neurosurgery, disc surgery is limited to those patients who are with motor involvement only. Having said that, nowadays people claim that the so-called micro discectomy has a better chance of success with less of a post surgical pain. This is a patient as an anesthetist. Now I'm taking off my palliative care hat and putting on the anesthetist hat, and we anesthetists are generally a bit needle happy. This is a patient in whom I will try epidural steroid injection. Now, significant improvement can be consistently obtained. My only caution will be, especially in somebody with significant osteoporosis, the potential problem is you take away the pain, all of a sudden the patient becomes very active, and that may cause a vertebral collapse if there is serious osteoporosis. So education of the patient and clarification of the risk is important. Secondly, if the patient is diabetic, any epidural steroid injection would be done only as an inpatient, because several times the blood sugar will have to be monitored, and that itself can be a problem. In a diabetic, the chance of a hematoma getting infected is high, and epidural injections can cause epidural hematoma. So with those cautions, I would treat the patient either with up to with the hydrocortisone injection, or with you may consider other steroids also. The risk, the advantage is that there is the perineural edema is reduced, so actual nerve compression reduces, and that gives the nerves the time to recover. So if in the next few days we are able to gradually mobilize the patient, the pain may not come back. Having said that, it is possible that with the movement, some worsening can occur in that a particular patient, elderly patient with osteoporosis. But if the patient is willing, that's what I would try. The second thing is just to keep on trying to juggle painkillers. In this patient, a combination of non-opioid plus an anticonvulsant may be advisable. Gina, I earlier complimented you on your choice for amitriptyline, but it appears that in patients with radiculopathy, anticonvulsants may seem to have a better chance of success. But the very elderly also get significant side effects with anticonvulsants.
Thank you, sir.
Welcome. Thank you, Manuel, for the question. Our time is up, so should I take a last question? Anybody? Okay, ladies and gentlemen, thank you for joining us. Look forward to being with you again day after tomorrow. Right? Day after tomorrow? Yes. Thank you.
Bye.